So, no breaks, just go on. I would like to welcome you to the next symposium, which I think is going to address a very innovative and interesting topic, which is the new technology of sirolimus coating for drug-coated balloons. And we want to discuss to which extent this might be the future for peripheral interventions. This symposium is kindly supported by Concept Medical and one of the leading companies in that particular space. So I have the honor to moderate this session, and together with some esteemed colleague here on the panel, we have Edward Choke, we have Ulf Teichgraber, and Francesco Liistro, and we will be joined online by Aloke Finn later on, Sahil Parak, and Stefano Barco. So I think we really have a number of lectures here lined up, which will be suitable to basically update you on the status of the Concept Medical sirolimus-coated balloon project from the technological basis over the current status of clinical trials and clinical applications. And feel free to always come back after the talks with questions, either at the microphone or scan the barcode, and you can also submit online questions. So with that, I would like to announce the first speaker. Aloke Finn is joining today virtually from the United States, and he's going to speak about whether sirolimus is a better option for PAD treatment.
I'm Aloke Finn. I'm from CVPath Institute. I'm going to talk about Magic Touch sirolimus-coated balloon with nanolute technology. Is sirolimus a better option for PAD intervention? Here are my disclosures. So this first slide goes over interventional progress. You can see there have been many stages or many devices or procedures that have been introduced for revascularization. I would tell you more recently we've had DCB's first gen, but the second gen sirolimus-coated balloon represents perhaps the epitome of 60 years of progress in interventional. Currently, paclitaxel drug-coated balloons are the dominant mode of revascularization for drug-coated balloons. You can see all the products listed here with their various doses of paclitaxel. Now, the problem is, of course, paclitaxel causes local depots of paclitaxel, which are lodged onto the arterial wall and elute over time, causing some evidence of inflammation, but some effectiveness in terms of restenosis prevention. The problem, of course, is the coating integrity is variable, and you can get loss of paclitaxel in the downstream tissues, which is inadvertent but important. Now, there's a paclitaxel dose-dependent toxicity response, which is well known in chemotherapy treatment. You can see at higher doses of paclitaxel, you start getting things like marrow suppression, neurotoxicity, alopecia. This is one of the worries or concerns of paclitaxel. Now, why do we need a sirolimus DCB? Well, it's a standard for coronary artery disease treatment via DES and for coronary arteries. The paclitaxel modifications, as I mentioned, cause loss of paclitaxel into downstream tissues. And loss of paclitaxel remains a significant safety concern and the results of Katsanos. And this has all been shown by us in preclinical models as well as clinical models showing slow flow after paclitaxel balloon deployment. You can see the anti-restenotic effect in coronary arteries is simply greater with sirolimus versus paclitaxel from this coronary stent data. So what is required to show safety in animal models? Well, we certainly need to show acceptable healing to the DCB both early and late. We also want to show that their downstream organs, emboli did not occur, and that peripheral vasculature was intact. There was no emboli there, and non-target organs were not affected, and then how much drug was lost before the delivery to the arterial wall. All these are important aspects to show. Sirolimus-coated balloons have certain technical challenges. Of course, tissue absorption is a problem, as well as tissue retention. Now, the nanolute technology on the sirolimus-coated balloon by Magic Touch shows that we really encapsulate the sirolimus into submicron-sized sirolimus into highly biocompatible phospholipid carrier. Upon inflation, the drug carrier with sirolimus gets transferred to the arterial wall. There it stays over time and elutes to cause a sustained drug release over time. And here's just a depiction of that, the submicron particles of phospholipid carrier and the direct spray coating onto the balloon surface. You can see this is effective. Here's the pharmacokinetic data from the Magic Touch balloon in porcine coronary artery showing effectiveness or detectable drug levels out to 60 days. Now, we did a GLP study looking at this in porcine femoral arteries. These are the time points chosen. I'm not going to go over all the details of this. We don't have time, but I'll show you some examples of the data. Here are the preclinical study. I'll show you the 28-day data with the Magic Touch versus 3X versus the control balloon. And you can see here, proteoglycan scores, muscle cell loss, scores, circumferential and depth were both greater with the Magic Touch than the POBA system, showing you effective drug delivery. And downstream data did not show evidence of distal embolization that caused myocardial infarction in a coronary model, showing that emboli are minimal and probably not significant. Conclusion, sirolimus is the preferred drug for intravascular interventions. Paclitaxel-coated balloons are limited by high rates of distal embolization. And these concerns were highlighted by the Katsanos analysis. Magic Touch demonstrates successful drug transfer arterial wall and received CE mark approval with FDA submission studies ongoing. Sirolimus-coated balloons undoubtedly will become an important technology for the treatment of PAD going forward. With that, thank you for your attention.
Well, thank you very much for a great introduction into the topic. I think we go on and become a bit more practical. A lot of the early pioneering work with this technology has been done actually in Singapore, and Dr. Edward Choke was the one which probably entered in the first clinical studies, and he's going to update us on the XTOSI 2-year results and also about future SFA and future BTK trials. Edward?
Thank you very much. So for the opportunity to present these 2 years results from the XTOSI trial, these are my disclosures. Chronic limb-threatening ischemia is a major health burden. Effective revascularization is the cornerstone of treatment, but this is often hampered by high rates of restenosis and also high rates of reintervention after conventional balloon angioplasty. So the XTOSI first-in-man clinical trial was designed to investigate the efficacy and safety of the Magic Touch sirolimus-coated balloon for peripheral arterial disease. It is a prospective pre-market non-randomized all-comers single-arm trial. The 12-month results were published last year, and for this presentation, I will focus on the 24 months clinical endpoint data. So this is the basic flow chart of the trial. 55 patients in total were screened and consented. 5 patients were not enrolled, and they did not receive the Magic Touch sirolimus-coated balloon. 50 patients were enrolled, and 40 patients underwent the 6 months primary patency endpoint by duplex ultrasound scan. So we now have complete follow-up up to 24 months, and this will be presented here. So very quickly, these have previously been published and presented. The key demographics and lesion characteristics are that these are high-risk patients, 90% diabetics, 36% coronary artery disease, 20% of patients were already on dialysis. These were almost exclusively CLTI patients. 94% of patients had Rutherford 5 and 6. Of those with wounds, more than 50% had Wi-Fi score of more than 4. In terms of the lesions treated, 30 patients had BTK lesions treated, 20 patients had femoral popliteal lesions treated, and the mean length was quite long at 227 millimeters. And 36% of these lesions were chronic total occlusions. So this is the key slide summarizing the headline data. These have already been published, but I just want to provide some perspectives on this data. The 6 months primary patency for BTK was reported at 74%, and we were quite encouraged by this result because we know that in our patient population from our previous RCT data, using conventional balloon angioplasty, we could only achieve 6 months primary patency for BTK of only 40%. So this was a significant improvement from our point of view. For SFA and popliteal arteries, the 6 months primary patency was 88%, and we know then from this early pilot data, although this is early, then this could at least match the excellent outcome reported for paclitaxel-coated balloons for 6 months primary patency for SFA popliteal, which have been published in the literature of between 85 to 90%. Now these are the 24 months data of secondary clinical endpoints. The freedom from CDTLR at 24 months remained excellent at 94% for FEMPOP and 86% for below the knee. Because this is a high-risk CLTI cohort of patients, the all-cause mortality was significant at 24 months, about 15% for FEMPOP and 21% for below the knee. And this was the component which contributed to the amputation-free survival of about 80% for FEMPOP at 24 months and 73% for below the knee for 24 months. And I'm pleased to report that at 24 months, the limb salvage success remains excellent at 94% for FEMPOP, and for below the knee, this was 91%. And at 24 months, of those patients who were still alive with intact legs, 100% remain ulcer-free. So this was a patient from the XTOSI trial who had severe diabetic foot sepsis requiring transmetatarsal amputation. And the magic touch sirolimus-coated balloon was applied to the SFA and popliteal. And at 6 months, with the help of skin grafting, his wound had healed completely. And at 6 months, the primary patency remained. And the primary patency was sustained to 12 months and also 24 months at 2 years, and he remained ulcer-free. And this was him back in my clinic about 2.5 years ago, and he was able to ambulate with no aid, and he informed me that he had gone back to work as a taxi driver. To be honest, at that point, I didn't quite believe that, but having seen him actually in real life, this was a sheer coincidence. I had returned from Charing Cross 2 months ago, and I was waiting for my taxi from the airport, and there he was, by sheer coincidence, just waiting, and he was the taxi driver for my trip home from the airport. This was another patient from the XTOSI trial. Baseline sirolimus-coated balloon was applied to the proximal anterior tibial artery. And at 6 months, the patency was maintained, and the wound had nearly completely healed. And at 12 months, the primary patency was maintained, and up to 2 years, the proximal ATA, which had been treated, remained patent. So to summarize the XTOSI 24 months data, Magic Touch PTA reported good 6 and 12 months primary patency, and at 24 months, the clinical outcomes were fantastic, low rates of reintervention, and high freedom from TLR in excess of 85%. High limb salvage rates of more than 90%, and of those patients who still had their legs and who were still alive, 100% remained ulcer-free. So I want to discuss a little bit more in detail about the issue with distal shedding and distal embolization with slow flow phenomenon from the paclitaxel drug-coated balloons. This was a patient who underwent atherectomy and POBA in order to achieve luminal gain for his in-stent occlusion of the SFA. And after application of the paclitaxel drug-coated balloon, you can see that there is a slow flow phenomenon, 2 steps forward, 1 step backwards, kind of a flow after application of the paclitaxel drug-coated balloon. In my experience, I've seen no slow flow phenomenon or distal embolization with the Magic Touch sirolimus-coated balloon. This was a case of a patient with severe diabetic foot sepsis requiring extensive debridement. And for this patient, we know that they usually require all their vessels open in order to try and maximize the chance of limb salvage. This was the baseline angiogram, diffuse stenosis of the ATA, peroneal, and CTO of the PTA, and the plantar arch was incomplete. And because of the extensive wound that we've got here, we knew that we had to try and reconstruct everything, including the plantar arch. And for this patient, the crossing was reasonably straightforward around the plantar arch using a command ES014 wire supported by a CXI Cook catheter 2.6 French. And following POBA, I went on to deploy a 3x200 Magic Touch sirolimus-coated balloon to the posterior tibial artery, followed by a 2x150 Magic Touch to the plantar artery. And this was the end result, showing reconstitution of the plantar arch following POBA. And following application of the Magic Touch PTA, you can still see that the flow down the PTA to the plantar arch remained brisk with no evidence of slow flow phenomenon. More proximally, you can see that post-POBA, there was reasonable flow down the peroneal artery and down the PTA. And post-deployment of the application of the Magic Touch sirolimus-coated balloon, you can see that the flows down the PTA remained brisk with no evidence of slow flow phenomenon. So with the sirolimus-coated balloon being fairly new technology, there is evidence that there's more and more acceptance of sirolimus by the vascular community for the peripheral arena. In this recent Charing Cross 2021 poll, more than 50% of the audience thought that limus was a better drug than paclitaxel. And this, of course, had been known by the cardiologists for some time already. In this paper published 17 years ago, they reported in their meta-analysis that sirolimus-based stents have been proven to have higher efficacy than paclitaxel. And there are several biological possibilities as to why sirolimus may be advantageous. For example, they've been thought to be more effective in inhibiting smooth muscle cell migration. They also got anti-inflammatory properties and immunosuppressive properties. They are cytostatic as opposed to being cytotoxic. But particularly, I wanted to focus on their anti-inflammatory properties and also their immunosuppressive properties. With a case history, this was a 37-year-old female in whom I used the sirolimus-coated balloon to treat vasculitis of her BTK arteries. She presented about 2 years ago with fulminant polyarteritis nodosa, which is a systemic inflammatory condition attacking medium-sized arteries causing severe vasculitis, and she presented with acute limb ischemia in October 2020. Hers was a particularly severe form of polyarteritis nodosa. She had also subarachnoid hemorrhages and also multiple strokes from the vasculitis. And the rheumatologist was having severe trouble trying to control this disease. Methotrexate was started, but this was not really controlling the disease. So they started her on IV cyclophosphamide, subsequently switched to IV rituximab, subsequently, more recently in the last 2 weeks, switched to an anti-tumor necrosis factor. She had been on prednisolone for some time. She was on aspirin. And from my point of view, it was not good that she had to be stopped her clopidogrel and her rivaroxaban because of her intracranial bleeding. So from my point of view, she underwent index angioplasty with a conventional balloon. This only managed to achieve 6 months durability. In 6 months, all her tibial arteries had reoccluded. So she needed a second intervention. And this time around, the durability was even worse. 4 months to another repeat reocclusion. And this time around, she had an ulcer in the dorsum of the foot and developing gangrene in her fourth toe. So her foot is in severe trouble at this stage. And we took a biopsy from the dorsum of the foot. It demonstrated and confirmed that there was severe perivascular inflammatory infiltrate composed of neutrophils and lymphocytes. This is not her picture. This is just a typical illustrative picture of also a case history of a patient with polyarteritis nodosa, and just illustrates the extensive inflammation around the medium-sized arteries. So at that stage, in the third angioplasty, we considered whether to use the Magic Touch sirolimus-coated balloon because of its immunosuppressive properties and also anti-inflammatory properties. So this was discussed with her. Completely outside of instructions for use, but this is in extremis and fairly exceptional circumstances. So in the third angioplasty, she was re-intervened with the Magic Touch sirolimus-coated balloon. And I'm pleased to say that 10 months on, she remained occlusion-free. You can see that there is already starting to form stenosis in the distal posterior tibial artery. Now, this is a severe inflammatory process, so I fully expect her disease to come back at some point. But for now, she remains occlusion-free. And her ulcer had completely healed with a remaining scar in the dorsum of the foot. So really, we've now got early pilot data on the use of sirolimus-coated balloon, but obviously, these are only early data and needs to be confirmed with randomized controlled trials. And there are 2 such trials being ongoing in Asia at the moment, the FUTURE SFA and the FUTURE BTK trial. The FUTURE SFA looks to recruit 279 patients, Rutherford 3 to 6. FUTURE BTK, 219 patients, Rutherford 4 to 6. These are the key characteristics of both trials. Both trials will be double-blinded, 2-to-1 enrollment, 2 SCB to 1 placebo. Recruitment across 18 sites, across 4 countries, Singapore, Taiwan, South Korea, and Thailand. Completely CRO controlled with core lab adjudication of the duplex and the angiogram pictures. Enrollment had already started, and for Singapore, I'm pleased to report that we are 50% of the way there. These are the flow chart of the trials. PAD patients will be screened. All will undergo standard angioplasty, and they will be randomized intraoperatively only after fulfilling their inclusion and exclusion criteria to receive either placebo or sirolimus drug-coated balloon. The primary outcome will be 6 months primary patency, defined as duplex PSVR of less than or equals to 2.4, core lab adjudicated, and completion of follow-up will be up to 24 months. So, in conclusion, Magic Touch PTA and XTOSI trial reported promising 6 and 12 months primary patency, and at 24 months, the clinical outcomes remain good, with high freedom from TLR, high limb salvage rates, and of those patients still alive with their legs, 100% remain ulcer-free. From my point of view, because most of my practice is on CLTI patients, I find the Magic Touch sirolimus-coated balloon to be ideal for BTK lesions because they have fairly safe in terms of application all the way down to the distal arteries, and also because of their anti-inflammatory and also immunosuppressive properties. However, obviously, we interpret this early data with caution, and we await the results of the ongoing RCTs that are happening all over the world at the moment. Thank you very much for your attention.
Yeah, thanks very much, Dr. Choke, for summarizing this early experience, and yeah, I think results indeed are promising. So, I mean, one of your conclusions was that we need randomized clinical trials. Ulf is the principal investigator of one of these trials, which is the head-to-head comparison of sirolimus versus paclitaxel balloons in the so-called SIRONA trial, and he will give us an update on this and other related projects.
Yeah, thank you already. Dirk, you already said everything. It really needs a head-to-head comparison. I think Eddie showed very promising data, but this is still only data which are actually one-armed study, so observational studies, which are very important because it gives us a hint where the direction is, and the head-to-head comparison, which I show here, the SIRONA trial, is actually a comparison between the Magic Touch versus those paclitaxel drug-coated balloons which we are on the daily use in Europe. We selected their 10 products which already demonstrated in randomized controlled trials their efficacy. And therefore, at the moment, we are nearly at the end of our enrollment. We started about a little bit more than 1 year, and we are now at 82.4% of participants. As you can see, we are aiming at 478 patients, and this is quite a high number for such a head-to-head comparison, and probably also at the moment the largest trial which is actually going on. I was asked to show not again the whole protocol, but what I want to show is a recent case from the study, and with this one I want to show how we actually are following by protocol. So a 64-year-old male patient with Rutherford 2 in the distal SFA. You can see is here a complete chronic occlusion of 40 millimeters in length on the right, in the right SFA, and as you can see here, we were able to recanalize directly intraluminally cross the lesion with guide wire intraluminally. This was quite easy, so it was not a complicated case, but these are the typical claudicants we are aiming for in this trial. And now the predilatation takes place. By protocol, we always try to have a safety margin regarding the length of the lesion of 1 centimeter above and below. And importantly, for both arms, we require or we strongly advise 180-second predilatation. This is by protocol, so that we have a clear predilatation. What takes now place is actually the randomization takes place after the predilatation, and this is probably also different to many other protocols in RCTs which are done before, because often the randomization is done before the predilatation. Why is this important? Because this is actually one of the main points for bias in trials. Once the investigator knows which kind of product he has, especially in a head-to-head comparison, someone might argue, well, the other one arm is pre-dilated and prepared differently. So this was one of the points where we really take attention to in this trial. Of course, then the DCB is applied, and by information of use for 60 seconds, and again in the same length as a predilatation balloon with 5 millimeter and 5 by 60 millimeter. In this case, the magic touch arm, and this was also done exactly then. And then you see the typical runoff. So this is a quite clear and simple protocol, making attention to the point when the randomization takes place. So this is what we are really aiming for. Of course, we are not only looking at short lesions. This was occlusive 4 centimeter lesions. It's allowed up to 20 centimeter lesions to be enclosed, and the minimum length is 2 centimeters. And now I want to come to our future, or yet now just started trial, the Limus RCT study design, which I want to give you some hints to. Well, someone might ask, Eddie, you showed us data of freedom from TLR after 1 year of 85% in very sick CLI patients and 100% healing rate. This is really promising, and it's nearly wonder healing, I would say, in this way. And now we really have to prove this. Is this really the case? And what is the standard of care is, of course, still for the BTK, not DCB. It's non-coated standard balloons, so POBA balloons. And therefore, we in Limus, we compare the sirolimus drug-coated balloon, Magic Touch, versus the POBA balloon. We are aiming for 230 patients in total, so 115 participants per CLI group, and we are recruiting in 19 sites in Germany and Austria. So POBA and provisional stenting in the infrapopliteal lesions is still the standard of care by guidelines, but we all know that is really unsatisfactory, and we need an alternative also there. And below the knee, the superiority of paclitaxel-coated balloon over POBA is still contradictory, and as well the long-term safety is also conflicting. Whether sirolimus, with its wider therapeutic range, is effective in the prevention of intrapopliteal restenosis and reocclusions remains still to be proven, and this is what we want to do in our Limus trial. So our design is a prospective one-to-one randomized controlled multi-center trial. This trial is actually investigator initiated, and the objective I already mentioned. And as PIs, we are doing this trial together. This means Dirk Scheiner, Thomas Zeller, and me, and together with 19 other sites. So the main inclusion criteria is a Rutherford category 4 to 6, so classical CLTI patients, and infrapopliteal is our target lesion, and we are now aiming we are aiming at total occlusive lesions. They can be de novo or not stented related re-occlusions, and single lesions or multiple lesions can be addressed as long as a single target vessel is smaller than 5 centimeters apart. And exclusion criteria, the main ones I just mentioned here, endovascular treatment with drug-coated devices within the 6 months prior to the index procedure. And this is something we want to change still in our protocol with the next amendment, is the infection grade 3. this will be remaining, or ischemia from grade 0 to 1 according to the Wi-Fi classification. This is a little bit disturbing. I think we will then restrict this to the exclusion to infection grade 3. The primary outcome for limus is the composite of limb salvage and primary patency at 6 months by Kaplan-Meier estimate. So how is our primary patency actually below the knee defined? This is the absence of a target lesion occlusion with restoration of inline flow to the ankle without the need of clinical driven TLR. So this is done by duplex and is also core lab adjudicated. And this is very important. Often it's nice to recanalize occlusive lesion, but if the outflow is not sufficient, so this has to be proven right afterwards by duplex or by angiography. So this is something which we definitely want also to be approved in this trial. We have also a second, so we call it a key secondary outcome. We are not powering our trial by this, but still this is our also a very important outcome. This is the composite of male POD, so major adverse limb events and preoperative death within the 30 days. And there we're also aiming for non-inferiority against POBA, so also to address the question of safety. And we have further other 25 secondary outcomes throughout 3 years of follow-up. As I mentioned, the primary endpoint is after after 6 months. Yeah, where are we now? We just started in the beginning of March. And we have right now 9 patients recruited, and this is also completely different to the situation we are with our other trial in the SFA and SIRONA. Really, we had no problems even with our shutdown of most of our centers in Germany and Austria during the Corona times. We were middle in this time, so most of the ambulatory care units were completely closed. Also at my hospital and also here in Leipzig it was very difficult, but still we were able to recruit our patients. And now here below the knee it really looks completely different. We are, even with 19 sites, we are very much behind our schedule, and this is also something where we have to consider again even to enlarge the number of sites in Germany just to meet our aim that we are finishing our recruitment within the next 2 years. So SIRONA is RCT, femoral popliteal artery for Rutherford category 2 to 4. So claudicants mainly. It's a head-to-head comparison with paclitaxel-coated balloons, which are on the market and have demonstrated clinical efficiency in randomized controlled trials. And the limus RCT is infrapopliteal. We are focusing on category 4 to 6 in CTLI patients, and our comparison is here a standard of care. POBA. Thank you.
Well, thank you very much, Ulf, for this presentation. In my eyes, a very solid approach with 2 randomized clinical trials. I must say I'm a bit biased being the PI of these trials. Yeah. So maybe let's get Sahil, who joined us in the meantime. I mean, Sahil, you are with your eyes of an experienced clinical scientist, does it make sense? Are these trials going to answer the important questions that you would have?
Yeah, I think, Dirk, thank you first for the kind invitation. I'm sorry I can't be there in person. I think the clinical trials are incredibly important. We've seen in the above knee space now, head-to-head trials have become the dominant way of choosing devices. And I think that for the above knee SFA space, the SIRONA trial is going to be incredibly important to our algorithm for treatment. I think for the below knee space, we are still plagued by difficulties with achieving a positive endpoint. And I think the approach that Ulf just showed is extremely important because at least here in the United States, to convince the FDA of safety and efficacy before we can get our payers to pay for the devices. We really have to convincingly show in an RCT that we have efficacy and safety. We have not yet seen anything other than the TAC device get approved in the last several years. And we're looking forward, hopefully, to seeing Saval and Life BTK come in the next year or so. But as we all appreciate, short segment scaffolds are not the standard treatment algorithm. We use long segment balloons, and having a drug-coated balloon is going to be critical. And without an RCT, I'm afraid we're not going to get it through our FDA.
So when you mentioned the high hurdle for getting an drug delivery device approved for the BTK application specifically in the US, I mean, what do you think is really the most critical clinical parameter, and how much of clinical advantage do we need to show in a trial?
Yeah, I think the margin would be between 10 and 15, maybe 20%. But the endpoints are critical. I think that what's very difficult is to show a composite of patency with clinical benefit. The Bologna space is so challenging in that we generally bundle Rutherford 4, 5, and 6 patients, and we often will exclude on the margin. So complex Rutherford 6 with high Wi-Fi are excluded. And Rutherford 4s can be a broad array of patients, some of whom actually have ischemia and some of whom have ischemia plus neuropathy. So really, it's the Rutherford 5 patients where I think we would see the most benefit. And in that group, if we see a composite endpoint difference of between 10 and 15%, that should be sufficient.
Yeah. And Aloke, I mean, to get you also involved there, I mean, you showed us your clinical, your preclinical data. I mean, so we've seen that, but tell us from your perspective, how good do you see are the chances here for sirolimus to meet these, expectations and hopes?
That's a great question, Dirk. I think that it's a very challenging space. The drug-coated balloons, generally, the concept solution, they do work. I think they do deliver the drug effectively. They will benefit. But what I'm more concerned about, Dirk, is I'm concerned about the pathophysiology of these lower extremity BTK occlusions. We showed in a recent paper, and I'm here in Stockholm presenting some data, that half the occlusions we saw were from proximal emboli. So they were thrombus that had embolized and organized. And so, I wonder whether or not we need to treat the patient as well as treat the vessel. And the surrounding medical therapy that's, I think, equally as important in these trials has to be state-of-the-art top line. And I would ask Sahil and maybe Josh, what should be the mandated, medical therapy for these patients when you revascularize for BTK?
Yeah, I think this is a point. Particularly, I had a big discussion because I wanted to have in the study, in the duel, not a double antiplatelet treatment, but I wanted to use a new oral anticoagulant. Yep. But it was a real difficult discussion, and at the end, I had to leave the idea. But the idea is this: that after we revascularize this long total occlusion, we put the patient with a new anticoagulant and not double antiplatelet treatment.
Yeah.
And then the other question, I guess, particularly below the knee, we mentioned that already several times, is very complex. Complex from the patient setting, also complex from the lesion specifics, long lesions, predominance of total occlusions. And I remember that particularly Francesco pointed out in previous work that really the occlusions are the ones which are at risk for reobstructions, for reocclusions, and restenosis. So that brings up the question whether drug delivery alone is the right concept for a trial. I agree for getting it approved. We have to keep our trials clean, and we have to hope that, let's say, one device, actually the sirolimus-coated balloon in that regard, does the job and does, let's say, improve the result. The question is whether it's realistic to expect that a single device can solve the problem. Do you think that maybe there should be, let's say, a successful trial design should also incorporate specific methods of vessel preparation, plaque removal, possibly in both arms as a baseline treatment, which is then topped with a specific mode of drug delivery?
I would tell you guys, I would like to see sub-randomization within the randomization. I know probably people aren't going to be in favor of that, but I think vessel prep and atherectomy or something like that prior to DCB would also answer another question we have, which is, what is the right way to approach this from the DCB standpoint? Does atherectomy improve outcomes before DCB rather than just a plain old balloon angioplasty? I guess, Sahil, you can comment on this.
Yeah, I would piggyback Aloke on that exactly, Dirk. I think that we've got now two compelling data sets that suggest that vessel prep may actually not make a big difference in drug efficacy. So, for example, very recently published was the chocolate touch data that Mehdi Shishabur presented at the American College of Cardiology. In that, there was a subgroup, a significant subgroup of patients who received atherectomy prior to either chocolate touch or Lutonix DCB, and there didn't seem to be a top-line difference in the outcomes, even when pre-treated with atherectomy. Similarly, recently, we just saw the Disrupt PAD3 data presented by Bill Gray at the SCA&I meeting in the US. And there too, the main difference was in the reduction of needs for stents in the FemPop segment by using pre-treatment with IVL. The overall TLR rates, if you adjusted for the stenting rates, were the same. Okay. And so I think it's clear that the biological efficacy of the drugs is strong. Pre-treatment may improve long-term patency because of mechanical effects, but whether or not it affects drug efficacy remains unclear. Neither of those studies, however, was done with a sirolimus device. Yeah. And so there may be differences between the drugs. So there's a lot more to be learned.
Yeah. Okay, I mean, I think that's reassuring in a way. I think in that regard, I think the LEMUS protocol is probably well written, so it leaves enough room for optimizing vessel prep with let's say standard methods, but it focuses really on the comparison of the drug efficacy versus the placebo.
It's a very focused protocol. We can't really answer these questions. I think first of all we have to answer the first question: is this what Eddie Schauk really observed in his cohort, the reality, as compared to POBA? And I think this is the main question. So 100% healing rate. I'm still very amazed to hear that in your patients.
Yeah, well, I'll just qualify that to say that, of course, it would be unrealistic to expect. It is not 100% limb salvage. Now, obviously, we do lose some legs. But of those patients who were still alive and who still had their legs intact at 24 months, there was no recurrence of their ulcers. I'd just like to comment on the trials. It's fantastic that we've got an array of trials, and these trials have got their own specific differences. In answer to just like to respond to the earlier comments, I think it would be unrealistic to expect Magic Charge sirolimus-coated balloon to be an answer to all our BTK problems. I think there is no such thing as one size fits all. For me, there are certain indications to use the Magic Charge sirolimus-coated balloons. And in BTK disease, it is a very heterogeneous disease. You've got focal stenosis, you've got multiple diffuse stenosis, then you've got the short CTOs, then you've got finally the long CTOs. I think Magic Charge sirolimus-coated balloon, from my experience in CLTI patients, works best for the diffuse stenosis. For the CTOs, I think some of these will require a different answer and solution. Perhaps scaffolds might be the answer, but it is very exciting in the next few years to see the pipeline of data coming out from these trials.
Great. So I think with this little discussion in between, we continue now with the next talk. And Francesco Liistro, he, I think, is known for some really good and provocative trial designs in the past. So here already the title stimulates our fantasy debate. BTK duell. So this really it sounds like a very serious comparison, and Francesco will update us on this study design.
Okay, thank you, Dirk. So up to now, we know that we have some drug elution technology applicable in BTK with stents, resorbable stents, and drug-eluting balloon. But in my opinion, due to the length of the lesion in BTK and the frequent involvement also of the distality, including the proximal below the ankle segments, DCB best matches this complex scenario. The last 3 randomized trials, the AQUART2, the AQUART BTK, and the IMPACT BTK, showed efficacy for the drug-coated balloon compared to balloon angioplasty in very long lesions, almost 20 centimeters, with a very high rate of chronic total occlusion, and showing a late luminal loss for paclitaxel, this specific paclitaxel balloon of 0.5, 0.3, and also the impact 0.89, almost significant, but only in 40 patients, 20 patients with the DCB. So we know that sirolimus is the next step forward. I guess, yes, I hope so. It's, of course, anti-restenotic, it's not cytotoxic, it's cytostatic. And of course, even if paclitaxel on balloons, it's easier to apply, we know that the absorption is not better, and sirolimus has a much wider therapeutic window and a higher safety margin. The most important thing, who will win this battle at the end, who will give us a lot of drug in the storage in the vessel that has a very slow velocity, slow rate of transforming from inactive to an active form. So the longer we have the drug active in the vessel, the better is the anti-restenotic effect. And also this new technology that bring nanolute technology, bring sirolimus inside this double member with an hydrophilic head and a lipophilic core inside can be the solution. So the debate, it's a duel, it's a battle between these 2 drugs, paclitaxel, we choose the Acotec DCB, the Litos DCB, and the sirolimus-coated balloon, the Magic Touch from Concept Medical. The study is a randomized 1-to-1 in 4 centers in Tuscany, and we hope to enroll 172 patients. We go in deep. This is the flowchart of the battle, and one of the most important things is that we have an optimal balloon angioplasty result before we randomize the patients, and not only by angiography, but also by external ultrasound evaluation. And after the randomization, we do the procedure, we randomize, then they have 3 months aspirin and clopidogrel, and then at 6 months we do the angiography, and at 12 months we do a duplex evaluation. We talk about the primary endpoint, which is the late luminal loss, and the secondary endpoints, 12 months target lesion revascularization, target lesion occlusion by duplex, and major amputation. We include patients with a Rutherford class major or equal to 4, stenosis occlusion of at least 4 centimeters. Runoff arch is really important, Kawarada class 1, 2, or 2B, or even a tarsal artery, but must fill directly the foot arch. Of course, the informed consent and optimal balloon angioplasty before randomization. We exclude patients that have a poor life expectancy, a pre-planned major amputation. Every patient before going in the cath lab has an evaluation by the diabetic foot specialist who tells us if the foot has to be amputated anyway. Contraindication for dual antiplatelet treatment and need for below the ankle angioplasty to restore the flow in the arch. That's the problem of the outflow. We accept the dorsalis and plantar open, also only the dorsalis, only the plantars. We don't accept if there are no dorsalis or plantars, but we may accept if there is a tarsal artery or a collateral from peroneal that is filling directly the arch. In this case, we can enroll the patients. Defining an optimal balloon angioplasty, this is a case of an anterotibial occlusion. We made an angioplasty, this is the result after the balloon. We proved this by angiography, but also by duplex from the proximal part of the anterotibial to the distal part. This is the most important thing. You can see in this case anterotibial occlusions, and this we learn from the coronary CTO. Coronary CTO, we put stents, drug-eluting stents. We have a higher restenosis compared to normal stenosis, but this is because we're used to undersize the stent in the chronic CTO. When you use IVUS in coronary CTO, then the rate of restenosis becomes the same of a simple lesion. And that's what I thought to put also in peripheral. Here in the vessel after reopen, you have the vessel size, the lumen size, which you see by angiography, and the plaque burden, which is the lumen size much smaller than the vessel size. This is the place where we have to deliver the paclitaxel, and we don't have to undersize the balloon, otherwise we give less drug. And if you follow the angiography, you put a 2.6 balloon. If you follow maybe the EVUS, you put a 3.5 balloon, so with a big difference. This is the case where we undersize the balloon at 3.0, but after the evaluation of the duplex, there is still stenosis. It's a 3.3 vessel. We put a 3.5 balloon. There is no more acceleration. And at the end, at 6 months, the vessel was perfect. So primary endpoint, we choose a late luminal loss for this study at 6 months and measure as a focal and also as a longitudinal analysis. Secondary endpoint, 12 months vessel occlusion, measure amputation, and target lesion revascularization. How did we calculate the sample size? We thought to enroll mean lesion length of 16 to 18 centimeters, CTO from 70 to 80%, diabetes more than 80%. Late luminal loss in this situation with the previous balloon was 0.5, so we expected a control angiography compliance or more than 90% like the previous studies, and a mortality rate of 5% a year, but there was no COVID at that time. And we needed, for a superiority and inferiority margin of 10% with a power of 80, 172 patients. So we started the study, 52 patients enrolled in my center. Another center started just now, but there are still 2 centers that didn't enroll. The problem is the instabilization of the hospital, and they blocked the beds, and so we are slowing the enrollment in the study. But up to now, I can give you the result of 46 patients. You see mean age was 76 and 75, 91 and 95% of diabetes, almost 40 and 44 renal insufficiency, a lot of previous revascularization without stents, of course, and the majority of patients is Rutherford class 5. You see the baseline inflow problem was in 34 versus 47, 49%. The majority, you see what disaster is the BTK. They have a lot of occlusion in the posterotibial, anterotibial, and calcification moderate to severe in almost 80% of the cases. The majority of the vessel treated is the anterotibial artery, followed by the posterotibial artery. The date of the procedure, the mean length was 27 centimeter and 23 centimeter, baseline occlusion in 75 and 77% of patients, the same reference vessel diameter, 3.1, and the MLD. And also the DCB diameter in length was almost 30 centimeter. We had a procedural success of 96% at the end of the procedure, but you will see that we have some dissection. So the clinical outcome that we have of this population, we have a 12 versus 13% of mortality, and we lost 2 patients for the COVID infection, 0 major amputation, 1 TLR in the paclitaxel and 2 in the sirolimus, 96% of success and 95% of a clinical success in the hospital because we have a reocclusion, 1 in each group before 24 hours in the hospital. And the cause was dissection, which was not possible to treat. But a follow-up angiography was performed in 18 versus 13, and we have quite similar restenosis rate, 16% versus 23%. So I show you some cases, 2 cases. This is a real BTK disease. We see very long occlusion of the anterotibial artery, but also a significant lesion in the peroneal artery. Very good runoff, which is difficult to find nowadays in these patients. We try to attach the lesion with a gladius, a knuckle gladius, very important wire for BTK, because you can use as a knuckle, but also as a directional wire. We have a dilation, 2.5 millimeter of diameter. We make a pre-dilatation with a long balloon, and then we check the flow. The flow was wide, quite good in the mid to the distal artery. So we apply the magic touch, and you see the anterotibial artery is fixed in this way. Then we approach the peroneal, 48 millimeter. We use a 3.0 per 80 millimeter balloon, and also here we obtain a very nice result. There was also the 6 months angiographic result. In this case is really important. You see also in the peroneal and in the anterotibial artery, the result was excellent, and you can see the increasing of the outflow at the level of the foot. The patient healed completely. In the case 2, we have an occlusion of the tibioperoneal trunk, but we have a very patent anterotibial artery which is filling all the arch. The problem of this guy was the heel. So we had to reopen the long occlusion of the peroneal artery. We approached it and we dilated. This was the intermediate result. There was some collaterals for the heels, so we decided to use a drug-coated balloon. The vessel was fine. This is the final result, and it's increasing the flow in the distal anterior and posterior branches of the peroneal. And there was also, this is funny because there was also a stenosis in the popliteal that we dilated with a conventional balloon. If we go to the final result, there was no stenosis, but at 6 months you can see it's coming back the stenosis in the popliteal treated with POBA, while the segment treated with the Magic Touch, the peroneal, is fully open, and there was also increasing of the runoff in the foot at the level of the heel. The third case, an anterotibial occlusion. You can see there is flow in the arch, reopen completely the artery. This is the final result. We didn't get the result at the angiography. We have the follow-up duplex at 12 months and 9 months, 9 and 12 months, which is the flow was good and perfect. So in conclusion, DCB, in my opinion, up to now is the proper drug-eluting device to match this BTK complex intervention scenario. New studies highlight the patency advantage of paclitaxel DCB over POBA. This debate BTK duel will provide a head-to-head comparison of paclitaxel and sirolimus DCB with a dedicated interventional strategy included in the protocol that will limit the procedural bias and will make the result more reliable. Thank you.
Thank you very much. Any comments to the talk?
Not a question, but a comment, actually. So I like to congratulate you on the design of the trial, and I particularly like the fact that you check the results of conventional balloon angioplasty with a duplex ultrasound before you decide what size trial balloon to use with a sirolimus-coated balloon. And I think this is a particularly important key consideration of success of the drug-coated balloon. Because in my experience, I think in the early days of using the drug-coated balloon, sirolimus-coated balloon, I think if you undersize it and if you use the 2 millimeter or 2.5 millimeters in the BTK arteries, the results are not so good. So really, I think that's a great part of the trial.
But as I told you before, the most important thing is that the manufacturer doesn't send the 2.0 and 2.5 balloon. So only 3.0 balloon in the cath lab, and the problem is solved.
Yeah. So similarly, for the future BTK trial, we limit the utilization of the drug-coated balloon to the minimum size of 3 millimeters for our future BTK trial as well.
Yeah.
Absolutely agree.
How is the medical therapy handled around these trials in terms of the two arms? I don't mean to perseverate about that, but I'm interested in knowing what the standard is of care.
For future BTK, it is aspirin and clopidogrel for 6 months minimum. And after that, it is up to the discretion of the physician.
And Eddie, no other anticoagulant on top of that, correct?
No.
Ulf? Yeah, I wonder, Francesco, is it really that easy that you can give a recommendation or a statement that 3 for all BTK in general? I mean, there are patients who are very tiny and also distal vessels. I'm a little bit frightened to do more damage than good if I'm oversizing, or isn't that a risk?
As you know, I had also Chinese experience, and Chinese are smaller. But the problem is not the diameter. The problem is the way you approach the lesion. So if you go also with a 3.0 after that you pre-dilated with a 2.5 and you go very slow, you inflate slowly, you grow up the pressure in 2 minutes, you never break the vessel.
Okay.
That's for sure. You don't have to include patients with a small vessel disease, because that is another story.
So Dirk, to you. Now in Limes, now we should go only for 3 millimeters? Or you might.
I don't think we need such resistive, restrictions in the protocol, but I think we need to raise the awareness that undersizing has really been an issue, particularly in BTK interventions. It has been an issue in the first SFA DCB trials, as we all know, the Lutonix trials. I mean, they suffered from being overly cautious. And in the BTK, I think already prior to the first DCB attempts, we realized that more luminal gain gives us a better starting point. And I think if we add a potent drug, which reduces the neointimal response to the injury, this is probably even a more viable concept. So at least there are, and in fact, I mean, angiographically, we underestimate the caliber of the arteries because of the plaque burden. Well, I think a very interesting technical point, I think, which we really should keep in our mind. So now we move on to the last presentation. Dr. Barco will give us an update on the SirPAD randomized trial.
Hello everyone, my name is Stefano Barco, staff member of the Department of Angiology of the University Hospital Zurich and head of research. We will discuss today the general design of the SirPAD randomized controlled trial at half of target enrollment, and also describe a case, exemplary case treated with sirolimus-coated balloon in the setting of the trial. These are my disclosures for today's presentation. The only relevant is the one from Concept Medical, who has provided a non-restricted grant for the conduction of the SirPAD trial. We will start with our case. He's a 63-year-old patient who has been experiencing new persisting wound in the foot since approximately 6 months ago. He has a progressive claudicatio with a maximum walking distance without pain of less than 50 meters. So the indication for the vascular treatment is given. Clinically, he has also sign of poor perfusion of the leg with a capillary nail refill test of more than 4 seconds. This is the oscillography. You can see here the AB index is still normal, but the TBI index is poor, particularly on the right side, and the curves indicates a hypoperfusion of the foot. If you look at the duplex sonography at baseline, you can see here a 50% stenosis of the arteria femoralis superficialis, superficial femoral artery, and here, however, also an occlusion or complete occlusion of the arteria popliteal in the distal part. There is still some minimal perfusion, but this is for sure not enough and possibly responsible of the symptomatology. So what is the rationale of drug-coated balloon for PAD? In other words, should we treat this patient with endovascularly and prefer a drug-coated balloon over a normal plain old balloon? So the rationale is that with drug-coated balloon, one could maintain the original anatomy, of course, without placing stents. This technique allows a homogeneous drug transfer into the vessel wall and supposedly avoid chronic inflammation because of no use of polymers. This also allows to balloon and to treat small caliber vessels for which no stent placement would be indicated. And ultimately, this should translate into a longer patency rate compared to plain old balloon or to stenting. What is, however, the difference between the two main treatment options that we have? Sirolimus-coated balloons, paclitaxel-coated balloon. One is a cytostatic, sirolimus, the other is cytotoxic. The margin of safety is also much different. It's 10-fold for sirolimus, only 100-fold for paclitaxel, and consequently the therapeutic range is also wider for sirolimus. Sirolimus has anti-inflammatory properties, paclitaxel has not, and there is also a key difference in terms of tissue absorption and tissue retention. Of note, there was some safety issue related to paclitaxel, and now there is a formal recommendation of performing longer follow-up times in the case one is conducting studies with these products, because in paclitaxel treated patient there was observed an increase in long-term mortality compared to plain old balloons. So there is a general recommendation of taking care of this safety issue in ongoing and future studies. So sirolimus balloons are characterized by an encapsulation of sirolimus particles drug into a biocompatible drug carrier phospholipid. So sirolimus particles are just below this layer of phospholipid, or inside this layer of phospholipid, and this would facilitate the adhesion of sirolimus on the balloon surface, and also a better and more homogeneous delivery into the vessel wall, but also a deeper delivery into the lesion. And this would translate in the end in a better in-tissue bioavailability of the medication, of the drug. I've just discussed the key eligibility criteria of the SirPAD trial in another session, but I would like to reemphasize here the key characteristics of this all-comer trial. So endovascular angioplasty for infrainguinal PAD and no participation in other studies are the key inclusion eligibility criteria of SirPAD. Important patients who are supposed to have a peripheral arterial disease, and they should also present with a clear target lesion, namely the main lesion considered responsible for signs and symptoms with stenosis in our patient would be that the occlusion or almost occlusion of the popliteal artery. We have two randomization arms, treatment arms, Magic Touch PTA sirolimus-coated balloon, and the plain old balloons, provided they are approved in the European Union. And patients are randomized in a 1-to-1 ratio and stratified for the severity state of the PAD. Primary efficacy outcome is a composite of two hard, clinically relevant outcomes: unplanned major amputation of the target limb and endovascular surgical revascularization, please pay attention, of the target lesion and for critical limb ischemia. So in the case the patient would require, this patient would require in the future a revascularization for critical limb ischemia of the common femoral artery, this would not count as a primary outcome, would count as a secondary outcome, but not as a primary outcome, because we define this patient target lesion as the popliteal artery stenosis. And these both outcomes should occur within 1 year of enrollment. This is the flow of the study. You can see here there are different ways we are now screening patients. There are outpatients or outpatients from other hospital, from our hospital, or are acutely healed patients from the emergency room, or are just our inpatients from other departments that are referred to us because of the PAD, irrespective of the severity of the PAD. Then a second angiographic screening, so notably the evaluation of the target lesion and the confirmation of the presence of a PAD with target lesion. And in the same day, cath lab randomization to the two treatments. Then there are multiple assessments over the first year for the primary efficacy outcome, and ultimately a safety analysis within 5 years for the primary safety outcome, all-cause death. You can see here how the angiography looked like before randomization. So at the time of angiographic screening, you can hear an amputated popliteal artery. Patient was then randomized and was randomized to the sirolimus arm. And then there was a preparation of the lesion with the dilatation with the plain old balloon, and subsequently a prolonged dilatation, 2 minutes with sirolimus-coated balloons. This is the result after prolonged dilatation, and this is also an overview of the cuff arteries. And we use a Magic Touch 100. As said, the target lesion was the popliteal artery. 6 months later, the patient had no claudicants intermittens. Here one can see a nice flow in the arteria popliteal. This is the distal superficial femoral artery, and 6 months later there was an almost complete healing of the lesions in the foot. Again, note that the study design protocol has been published very recently. It's published in Trials. Here you can find all the characteristics of the SirPAD trials that is designed exactly to answer the question whether these kind of patients should be primarily treated with a prolonged dilatation of sirolimus-coated balloons or with the plain old balloons, and whether the sirolimus-coated balloons are providing an advantage in terms of hard clinical outcomes. We have now completed almost 50% of the planned enrollment, 1,200. We have now enrolled 537 patients in 550 days at 2 Swiss centers, and we are expecting to complete enrollment in approximately 18 months. You can see here the general characteristics of the study population. First, I would like to emphasize that screening failure was only 5-6% of eligible patients. It's really a real-world trial with consecutive patients. The main reason for not enrolling patients was the language barrier, so the patient was not able to provide informed consent or just didn't want to participate. In this group of 537 patients, we had 24 patients with critical limb ischemia and 41 patients who received prior endovascular revascularization. We have just performed an initial safety analysis only for the first 150 patients that has been requested by our ethical commission at fixed multiples of 150 patients completing 1 year of follow-up. We can confirm that there was no safety issue until now for the use of sirolimus-coated balloon, but also that the overall population was a sick population reflecting its real-world characteristics. The 1.5-year mortality rate was approximately 17% until now. As I said, there was no signal that sirolimus-coated balloon were characterized by a higher mortality rate. We will now perform a second safety analysis after the enrollment of 300 patients plus 1 year follow-up and so on. And with this, I would like to thank you very much for your attention. This is the old group from Zurich and from the Cantonal Hospital of Fribourg in Switzerland, who's taking care also of enrollment and study conduction. This is the group photo after the enrollment of the first patient on the 3rd of November 2020. Thank you very much for your attention again. I'm happy to discuss further with you.
Yeah, thank you very much. So another great study, well underway. I think we are already relatively late here in this symposium. Was a lot of content. We've seen we heard about a good potential for this new sirolimus-based coding on a preclinical level from Aloke, and we went through all the ongoing trial projects, including actually only randomized clinical trials. So this is really and with different designs, comparing against plain balloon, but also against paclitaxel-coated balloons were appropriate. So I really think it's a very profound and sound clinical research concept. I can only congratulate Concept Medical for really having the power to support all that in parallel, which is certainly not unique, which is certainly unique. Naturally we have to be patient despite the fact that the trials are well underway. It will take probably at least a year to get some initial snapshots of the final primary endpoints. But there is a lot to be expected, and thank you very much for today to all the speakers, and this concludes this session.
Thank you.